Here it is.
Okay.
Because when people start pouring in, I forget things like that. So good to get it now. So for folks who are not on the board or staff of the board, if you wouldn't mind signing in the chat with your agency affiliation, if you are affiliated, it's very helpful later when we're working on the minutes. Thank you for doing that.
Through this time.
So I think there are 5 board members on the call now. So Joe, Elaine Palencia, Matt Hausman, Daphne Maurer, and James Brandel. So is that enough, Stephanie, to start?
So. 5:46, and we can go ahead and do a roll call.
Susan Fowler. Matt Hausman.
Here.
Daphne Maurer.
Yes.
Elaine Palencia.
Here.
Kyle Patterson. Julian Rappaport. Jane Sprandel.
Here.
John Paul Joachim. Joe Omo Osagie.
Here.
We have 5.
We move to approve the agenda.
Oh yeah, I will share the agenda. Sorry. There it is.
Someone move to approve the. Yeah, move to approve the agenda.
Move to approve the agenda.
I'll second it.
Thank you. So, citizen input.
Well, do you have any discussion about the agenda before y'all vote?
Anything?
No.
Matt Hausman.
Yes.
Daphne Maurer.
Yes. Yes.
Palencia, Elaine Palencia.
Yes.
Jane Sprandel.
Yes.
Joe Omo Osagie.
Yes. Do you have anybody out there, Lynn?
There's no one here to give citizen participation. Maybe someone on the Zoom meeting wants to. And I-
Anyone on Zoom call have a thing to add? Okay.
So I'll go look out in the parking lot and I'll lock the door and I'll see you all in a couple minutes.
Okay. So talk about a minute. There's 1, 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1. 2, 1 So I'll go ahead with my comments. So this is supposed to be Dr. Julian Rappaport's last official meeting, and also Dr. Susan Fowler's official meeting as board members. Julian has been a board member about 10 years now, and Susan about 8 years. And they have contributed immensely to our conversations and to what we have tried to do as a community. I think Julian might be here eventually, but Dr. Fowler will not be here, unfortunately. Her husband passed away earlier this week, and so she will not be here. There's a card circulating. If you want to sign it, it's in the office. To sign a condolence for Susan as she goes through this time. If Julian comes in, we would like to make a statement at some point in the meeting. Hopefully, we'll get a chance of a few minutes to give him the floor. After 10 years of being part of the board, question is back and forth for quite a few of us. So, but they'll be greatly missed. 10 and 8 years, and we have a lot of 18 years that we will not have on the board. So those are my comments. We'll move on to executive director comments.
Well, I don't have a lot to add. It's a pretty full agenda. There's some action for you, but before the action, like there's, approval of minutes, but then a presentation that I'm very excited about, two actually, but the crisis response system presentation is something we've looked forward to for quite a while. I'm really happy to be able to have this before the end of the year, and really grateful to Gail Rainey and her team for putting this together, Leon Bryson for coordinating all of it. And then after that, we have a brief presentation about a student project, and then we'll get back to some action items that I hope it will be really smooth. So, to wrap these items up, you've seen them a couple times, the 3-year plan, the priorities document, and the funding guidelines. And then after that, it's just information and discussion as you like. So with that, and I'm sitting near the holiday decorations to try to, get the holiday spirit myself and maybe pass it along to y'all through Zoom.
We'll try.
All right.
That's the least we can do. Okay, let's move to approve the agenda. Approval of the minutes for the last.
So there's a meeting from last month, and there's also the joint study session minutes. Here they are too. The same date. For y'all, it was one really long meeting, but it was really 2 different meetings. So 2 sets of minutes.
Can we approve them in the same step? Can we approve them at the same time?
Yeah, I think so. If you make the motion like that. Yeah.
So you're going to make a motion to approve both the meeting and the joint session.
Move to approve the minutes from the regular board meeting and the joint session.
I can second that.
I put the link to the full board agenda into the chat. I hope that, or the full board packet. We normally send that to board members, and then hopefully folks will know where to look for that online, but just to make it a little easier, it's in the chat. Sorry. Do you want to see the minutes again?
So Stephanie, going to roll call?
Sure. Matt Hausman,
Yes.
Daphne Maurer,
Yes.
Elaine Valencia,
I said yes, my internet connection says it's unstable.
Yeah, keep freezing.
Kyle Patterson,
Yes.
Jane Sprandel,
Yes.
Joe Omosagie.
Yes. Okay. New business. Crisis response system. Gail Rainey.
So, Gail, if you have the presentation and you want to control it, you can share your screen. You should be able to.
Okay, I'll go ahead and do that. Thank you, Lynn.
Okay.
And thank you, Joe.
no.
We're really excited to be here tonight. I only hope we can live up to the hype that Lynn made for us. As we go through the presentation, you'll start to see some of what we currently have, and then what we are implementing. We're actually in the process of implementing some of the pieces, and some are still planned to come. And then we'll take you through overall system-wide, not just Rosecrans things, but system-wide crisis response pieces that are being implemented across the country, and then what Illinois is trying to do with it as well. And I'll kind of give an update on where we're at. We just had a meeting today. We were hoping we would get some more answers. Instead, we have more questions. So I'll try to help everyone through that. So let me share my screen here. Just a second. And I'm happy to have with me tonight two very talented people from Rosecrans, Dave Keller-Halls, who's a LCPC, and Melissa Pappas, who's also an LCPC. They are both integral in managing and supervising and implementing all of the things that are coming our way with the changes that are coming, and also the pieces that we currently have at Rosecrans. So Dave, I'll let you go ahead and give a little bit more information about yourself, and then you can go ahead and get started on and let me know when you're ready for the first slide.
All right. Well, thanks for that introduction, Gail. Thanks for having us, everyone. So I started my career in crisis, actually. It was back in 2010, and fresh out of school, and wanted to pursue mental health, but just wasn't quite sure where to start in a small town. So one of the first places you can start is as a bachelor level is a crisis response team. So I spent about 3 years in that field, or in that department, and learned quite a bit very fast, and realized I needed to get back into school if I was really going to be effective, not effective, but be able to continue my to move forward. So I did that and did a stint in outpatient for an internship, and wasn't quite my speed. So I went back to crisis because it was something that I enjoyed, as stressful as it was and hard to see some of the things you saw. It was nice to be able to help someone in the moment and really see some change, or at least find the right level of care for them. So I did that for another year, and I realized I wanted to move to another venue. And so I got into the Pavilion Behavioral Health and started doing case management on the youth and adult units there. I felt like I owed it to the individuals that I was sending to the hospital to see what it was all about. And so I spent almost 5 years there, flexing from the youth unit to the adult unit, and then ending on the adult unit, but did about a year in the pediatric unit that was brand new. So learned a lot very quickly there. We had an interdisciplinary team with a psychiatrist and nursing and rec therapy and dietary. So I just learned so much about that setting, and I really enjoyed it, and probably was going to stick it out there. And this opportunity at Rosecrans came about, and decided I wanted to get back into that community health, community mental health realm, because I knew that at the pavilion, we were struggling to find good discharge plans for people because of the lack of available services, as you all know. So jumped threw my hat in this ring, and I'm glad to be here. The Rosecrans family's been great. So all right, I think we can go with that first slide there. So I'm going to just go through some of our crisis related services. Not all of them are necessarily TAD crisis, but they fit into that continuum very well. So many of you are maybe familiar with the mobile crisis response team. You can find them in responding to schools, responding to the hospital, to the law enforcement agencies, to adolescent and children homes. Pretty much anywhere a crisis is unraveling, we can respond to that. So that we've got the Crisis Respite Center, also known as CRC, which we'll talk more about. And then our supervised and supportive residential, we'll talk about the differences between that and the continuum into that, and as well as our community support / case management team. So our mobile crisis response, 24 hours, 7 days a week, all year, every year. And there's the number there. If you guys aren't familiar with it, it's good to just have on hand to give out as you encounter individuals that may need it. And so we respond to all ages, regardless of payer source. And I know that sounds different than maybe in the past, where we really had to determine if it was Medicaid or private insurance, and then that dictated how we responded and who responded. And so thankfully with these new crisis services coming out with the grant, we're able to respond to every individual regardless of their insurance source. So that mobile crisis response includes a crisis assessment, along with some brief counseling or therapy depending on the situation, determination of a disposition, whether that be a form of community stabilization or seeking higher level of care like a CRC or an inpatient psychiatric facility. Of course, our goal is always community stabilization. Sometimes it's not possible, but our goal is to keep individuals out of the hospital if at all possible. And that's where a lot of this crisis continuum comes into play to help with that. Whether they're deflected or hospitalized, there's a linkage, whether it be to the hospital or linked to counseling, case management, resources like basic needs, whatever it is that individual and their family may need to help stabilize them, as well as prevent another crisis or incident from occurring. And then more recently, we've developed an internal follow-up component to it, because it's been so difficult to get people into counseling and case management, including our own agency. It's getting better, but it was in response to long wait lists. And so what this allowed individuals to do if they were seen in crisis, whether they were deflected or hospitalized, our crisis workers also acted as like a sort of counseling case management in the meantime. So it was about a 90-day period of a follow-up. So whether they're at the hospital or not, we follow up within 48 hours to check on them, see how things are going, schedule that next appointment to do a further more in-depth assessment, develop a treatment plan, and then work with them while we wait to get them to that next step, to that more permanent clinician. And we've been lucky enough to partner with Promise Healthcare, as we don't currently have a psychiatrist, although one is on the horizon. Promise has been great with us in reserving crisis psychiatric appointments for us, for individuals that may not need hospitalization, but certainly need to get seen by a psychiatrist and probably on medications fairly quickly to help them stay on track and stay stabilized. And that's that was the Walnut location there, which is where they're currently housed. And here you can see the Crisis Respite Center, or Crisis Residential Center, or CRC is what it's commonly referred to as. And if you're familiar with that building there, that is not part of, but we share a building with CU at Home. So we are on the far west side there off of Market, very tiny little place. It's only 7 beds. We're looking at relocating. Some of you may know we've been looking in the community for a bigger spot. But for now, we've got 7 beds, and the community loves it. Our local psychiatric hospitals love it. Even EDs sometimes when it's not quite hospitalization level, but they still need stabilization. So it's it's a 14-day program. It's completely voluntary. So when people enter, we encourage them to stay the whole time. Even if they're feeling better after a week, we want them to get the full experience. And so that includes therapy groups, individual therapy, case management. We help with getting over to Walnut to see the psychiatrist for medication monitoring and those kinds of evaluations, as well as other outpatient appointments that they may have, even medical and things like benefits and Social Security, getting IDs, all of that. So again, if they're considered safe to go out in the community, we're able to accompany them to get some of that stuff done. And so again, tiny, only 7 beds. I think we could double that and probably keep it full. So that's something that we're looking into as well. And it tends to serve as an entry point into some of our other housing or residential services. So first up, a lot of individuals, if there's a bed available and they're appropriate and they're motivated, there is what we call supervised residential, aka our group homes. So we've got 2 homes, 8 in one and 5 in the other. And that's about roughly a 6 months to a year program. And so what we'd like to see those individuals accomplish during that time is increased ability to care for themselves in an independent living. So a lot of the group home is set around learning how to cook for themselves, go to the grocery store, navigate the community in ways that many of us take for granted because we were taught it at a young age or it just caught on very quickly. And so we're helping them with some of those basic skills while also providing individual and group therapy during the day. And so again, the ideal goal is for them to move on to a more independent living, which we do have another setting, kind of a next step before they're out on their own, which is what we call our supportive residential. And that is a 1 apartment complex with 8 efficiency units for those individuals that have sort of passed the test of supervise and they have reached the next level. And there is no longer necessarily 24-hour staff available like there was at the group home, but they do have a case manager that's assigned to them to check on them weekly or multiple times a week to make sure they're keeping up on all of the things that they need to do to maintain their stable living and all the other things that they were learning from previous program. And then they may also be involved in other outpatient programs within Rosecrans. So again, we'd like to have more units, but we're stuck with only 8 at the moment, and those fill up fast. So our community support team, currently only serving adults, so 18 and up. We at the time that we made this slide, we only had 3 full-time case managers. We've got 2 more that are starting before the end of the year, and we're hoping to get them trained up and be able to really address the wait list and get the flow going again and the access available. And so these individuals are community-based. They spend about 60% of their time out in the community, meeting the individuals at their home, wherever they feel comfortable meeting, and about 40% in the office. And this population tends to be our severe mentally ill individuals that have struggled since maybe being diagnosed or not had some of the natural supports, resources, and maybe even stable housing that that they need to maintain their mental health. So,
a quick question, Dave, if I could, because you said something that I'm a little confused by.
Sure.
So you said, so now when you're talking about the 3 full-time case managers, are they supporting the ones in the 8-unit apartment building, or are they supporting people who are kind of more closer to fully independent?
So a little bit of both. So, and thank you for pointing that out. So we have a specific designated case manager, not included in these three full-time case managers, that is our supported living case manager. And so she manages all 8 of those clients. Unless they are needing a little more intensive case management services, then we would link them with one of these community support case managers. However, because we've been so short-staffed in community support, we've really relied on her to try to manage all 8 of them on her own, which she's done a pretty good job of, to free up those caseloads for individuals in the community that are a little more independent.
Because was most of my question was, you made a comment about hiring the 2 new case managers and helping with the wait list. So is the wait list more based on the staffing than it is space?
Yes. When it comes to outpatient, it's more about staff.
Okay.
Yep.
All right. Thank you.
You're welcome. Thank you. Good questions.
Great, thank you, Dave.
Does the CRC have detox?
No. Oh, no. CRC does not have detox capabilities. That is actually one of the things that if someone is detoxing, we ask that they detox before coming in, because we don't actually have the medical capabilities to manage that type of thing.
So John has his hand up. Go ahead, John.
For the crisis respite, it says you have a 14-day program. I was wondering, is it an evidence-based medicine guidelines that you guys are following, or is it just a program that you guys developed, or can you elaborate more on that?
Sure. Yeah, it's more therapy and case management based. So there is not a psychiatrist attached to it. We again partner with Promise Healthcare to manage those individuals that need medication. So within 24 to 48 hours of admission, we have them set up with typically it's Dr. Yang or Dr. Su over at Promise to manage their medication. And then based on his orders and recommendations, our staff there then assist with that. In terms of evidence-based therapy, though, yes, we tend to lean on the more evidence-based, like CBT and DBT for the therapy groups and individual.
Excellent, thank you.
Mhm.
Any other questions, please? Thanks.
So those are the services that we currently have in place, and we have some new and upcoming services. Melissa Pappas is actually the supervisor of all of the new and upcoming pieces that we're going to be talking about tonight. So Melissa, I'll let you go ahead and give a little bit of background real quickly. I'm looking at the time and want to be cognizant of the board's time. And then if you can just give a introduction to the services that are coming up.
Sure. Hi, everybody. My name is Melissa Pappas. I started my career in community substance abuse treatment, outpatient, and I ran our IOP group in Southern Illinois. I then decided to go more into the mental health realm. So I began working for the Illinois Department of Corrections. I worked in a maximum security male prison. I worked primarily with individuals who used to be on death row and whose sentences were commuted to life sentences. And then I also worked with individuals with prolonged or indeterminate segregation time. I worked in the Illinois Department of Corrections for almost 7 years. And then in order to take care of myself, because it's a very, very difficult environment to work in, I went and became a clinical supervisor at Nexus Family Healing for a residential treatment facility that worked with youth males with sexually problematic behaviors. I worked for them for about almost a year, and then an opportunity came up here at Rosecrans for a position that nobody really knew anything about. Nobody really knew what we were going to do, but I knew that I was going to implement these new programs with this grant that we got. So it was pretty exciting, and I couldn't pass it up. And I was like, well, this kind of sounds incredibly interesting. So I'm going today to talk to you about kind of the new programs that have been spawned from the CCBHC grant and what our hopes are for these, the implementation of these new programs. So first and foremost, we're gonna, a quick overview. The three main programs that we are bringing to Champaign County are CCRT team, which is the Crisis Co-Responder Team, the Living Room Program, and the ACT program, which stands for Assertive Community Treatment. So Gail, do you want? Awesome. So the Crisis Co-Responder Team, currently we are partnered with Urbana Police Department for our Crisis Co-Responder Team. And we recently just gained commitment from Champaign Police Department and Champaign Fire. So we will be able to be expanding these services hopefully sometime early next year. So what does the Crisis Co-Responder Team do? Well, it's a follow-up program that involves a Crisis Co-Responder team member and a team member from law enforcement who has to be trained in crisis intervention. And they provide all the follow-up services for calls that were designated mental health related calls. So what hopes do we have for this program? Well, to decrease overall 911 usage and interactions with the criminal justice system. So whenever the CCRT team is given a referral, they follow up with the individual within 24 hours of that referral. So what we are trying to do is recognize the crises that are occurring in the community that are mental health related, de-escalate, assess, and try and connect these individuals to services so that their utilization of 911 or law enforcement decreases. Also, as a whole, this will strengthen the community and appropriately use services for these individuals. And we also want to really get law enforcement involved with mental health treatment and care for these individuals. So kind of how is the referral process? Every report that is deemed like a mental health report is identified as a CIT report. Those CIT reports are given to the CCRT team and they complete that follow-up contact. During that follow-up contact, what they're kind of doing is they're providing brief case management services or linkage services to programs for these individuals that the report was originally made on. So a lot of times they are providing these services to what we call a super utilizer. So individuals that are either in multiple programs within the community or have multiple engagements with the police, oftentimes weekly. And by providing these case management services for them or linking them up to other services, we are seeing right now currently a reduction in 911 calls. We are also seeing a reduction in individual crisis situations. And although we haven't seen significant increase in stability, we have seen stability in them leaning on and utilizing 911 for that support. Also, our CCRT team is really kind of putting boots to the ground and providing education to the public to assist in decreasing this stigma, this negative stigma that is still associated with mental illness. So they are kind of our first responders with education as well to community members. So this, the Living Room program is one program that is very near and dear to my heart. It is a program that I am so excited to bring to Champaign. It is coming in January of 2022. The Living Room program is a program that is designed to provide a safe, comfortable, non-clinical space for individuals to utilize, regardless of payer source, regardless of being a Rosecrans client, to utilize before a crisis situation occurs or to avoid escalation into a crisis. This program can also be utilized as an after crisis place to go to kind of process what happened. This is a solely peer-based service. The two individuals that will be running the program have specific credentials to be what we call a peer support specialist. They will help the individuals develop recovery plans, connect them to resources that they need to hopefully prevent future crises. They will also kind of be that, I like to think of like a beacon of light whenever a lot of people think it's a really dark time for them. Our hope is that we decrease the utilization of the ER whenever people are going there just to get that emotional support at times. The living room program will take those individuals and be able to provide them with the support that they need. And that way we are not crowding emergency rooms to kind of get that need met. We also really want to utilize this program to break the cycle of isolation. Mental illness can be incredibly isolating, and so can substance abuse issues. And so this is an open door where nobody has to feel alone. And what it also, the main kind of the main statement for this program is that it is going to develop peer-based support networks, because it is peers that are operating the program, and they are the ones that are providing the support for these individuals. The last program that I'm here to talk to you guys about today is the Assertive Community Treatment Team that we are bringing to Champaign County, or what is also known as ACT. This program, I like to call it case management on steroids. This is intensive case management services for the significantly and seriously mentally ill and co-occurring disorder population. These services, as Dave was explaining, his case management services, it's 60% in the community, 40% in like an office space. For ACT, it is 80% community work, 20% office. Also, individuals in the ACT program have to meet very strict kind of requirements to be in the program. They have to meet certain diagnoses and certain functional deficits in order to be considered for the program. The ACT team is comprised of 5 individuals. You have the team leader, you have 3 case managers, all with a specialty, a lived experience case manager, vocational case manager, and a certified alcohol and drug counselor case manager. And then you also have an ACT RN. Those 5 people share the entire ACT caseload. The caseloads are much smaller than what you would see in other case management programs. It's only about 12 to 15 per caseload, and every team member plays a role in that individual's life. So the case manager for vocational is the one helping them find a job or maybe housing. The CADC is maybe helping them with their addiction. And then the nurse is helping them with medication management and education. So these individuals are seen multiple times a week to help increase their functionality within the community.
Thank you, Melissa. Um, as you can see, there are a lot of parts to this puzzle, and Rosecrans by no means is the only provider of services that are related to crisis services. We have multiple partners in the community, and there are other providers as well that are doing some services to help support all of these pieces. The landscape for crisis services continues to change. SAMHSA came out with a large report, over 600 pages, of what they would like us to do at a federal level, and it's trickling down to the state level and local level now, to show us all of the pieces that can be put into place to create a full continuum of services for crisis in general. There are multiple pieces of legislation as well that are tied to some of the changes that you're seeing. You'll be seeing it at every level. The community support pieces, the concentration that we talked about already, where we're doing the co-responder pieces, we're with first responders, we're also meeting people where they're at in the community. Clinical best practices continue to evolve and change with some of these pieces. There's becoming more and more emphasis on the peer support, which a lot of us have known all along works great, but now we actually have the research to show it, and people are starting to actually pay for some of those things as well, which is amazing and wonderful, and a way that we're seeing the trends moving. As we talked about, the whole array of services is needed in order to meet all of the different needs, and different pieces of the puzzle play a role depending upon each person's different situation and where they're at. And then as a funding organization and a government organization, even the 708 boards are being impacted by this as well, where different parts are being funded in different ways, and the structure is actually different throughout the entire country, and then it's different within each state, and then it even is different for each locale. So very broadly, some of the things that are being implemented across the board, due to the National Suicide Hotline Designation Act in 2020, the 988 system is coming. The deadline for implementation is July of 2022. So July coming up. We'll see if everyone's ready for this because it is a huge shift in how things go as far as the very beginning of the entire process, where there's a call that comes in, generally speaking. And like I said, SAMHSA sent out their report on crisis services, and it all evolves around 6 of their core principles. We've pretty much talked about every single one of these already tonight, where it's focused on recovery. There's a role for the persons with lived experience. Peers are a big piece of the puzzle. Trauma-informed care is a piece of everything we do, and looking at trying to reduce the suicides. And of course, the goal would be to have 0 suicide, period. Safety and security protocols in place, and then we talked about already the partnerships with first responders as well. So all of those are pieces that are coming at a federal level. That comes down to the state level as well, where the Community Emergency Services and Supports Act, or CESA, as some people have called it, came about in Illinois, and people are trying to adjust to all of the different requirements that are involved in that legislation, which focuses mainly on first responders. And then the Department of Mental Health in the state of Illinois continues to want to emphasize that they are not getting rid of the community-based programs. In fact, they know they have to preserve and bolster the community-based programs that already do exist, but then there has to be an expansion of services so that more people can access services quicker. And out of all of that, also, we already know this, and we're looking at more ways to enhance the coordination of care to be able to make this all work and to be successful. It's a lot of work. There's a lot of unanswered questions. If you ask about, well, what's the 988 piece going to look like in Illinois? I can honestly say right this minute, we don't know. The state put out an RFP for a call center to cover the entire state, but then what? And how do the calls get from not the 988 call center to the locals? All of those pieces are actually still being developed as we speak. Dave and I had the pleasure of being on a crisis learning community today with the state of Illinois. And some of these things, we understand all of the philosophical pieces, we understand the models, but what exactly the state requirements are going to be for some of the pieces of the puzzle still remain to be seen. So we are indeed building some of the pieces of the airplane as we go down the runway. Some of them already exist, thankfully, and we're able to adapt. But you will be able, I think, even locally, we'll be seeing more and more changes in the coming year or so because of all of the massive amounts of change across the country and at the state level.
Matthew has a hand up.
Yeah, I had a question about the, excuse me, the co-response teams. And your, as you mentioned multiple times, the law enforcement, first responders, and you had a note in there about expansion to other ones. And I'm curious, is that including say Rantoul and then the sheriff's office to get some of the outlying areas outside of Champaign-Urbana covered?
That is definitely our goal.
Okay.
Yes. We would love to expand this program as much as we possibly can. We think it not only helps the community, but it also is a benefit to the law enforcement officers as well, because we are providing them with education and understanding with working with a population that can be both scary and frustrating at times for people that aren't in it like we are. And so I think the program is twofold. It benefits the community and also benefits the agencies as well.
And I think we do need to note there are other providers as well besides
Yes.
Rosecrans that are working within the community to help provide some of these services also.
Mhm.
I have a question or comment. I really love the way this is all being reimagined, kind of away from a kind of a binary of here's an office and here's somebody who needs something. You know, I really love that. I wanted to ask about the living room program. Is a little bit more, is that a drop-in center? I couldn't quite get how people get in and out.
Yeah, so yes, that's a good way to explain it. It is going to be located at our Walnut location in a very large room that we are now recreating to actually make it look like a living room. We're going to have couches and it be very warm and comforting. People can come in, get water, food, have access to resources, have access to computers set up for them. It will be open Monday through Friday, 10 to 6. And we are creating like a doorbell system. We have a door on the side of Walnut that they could ring the doorbell and a living room employee will come and greet them and walk them to the program. And there's no time limit to stay there. They could stay there all day. They could stay there 5 minutes. But yes, it will be, my goal is to hopefully at one point have it be open 7 days a week. Right now, we're going to start with 5 and see how it goes.
Okay, thank you.
Mhm.
Sounds good.
Question with regard to the ACT program.
Mhm.
How do you decide which individuals are going to go into that program? I know, I understand probably the really chronically mentally ill and those illnesses, but are these people coming out of the hospital? Are these people that have lost follow-up at the community behavioral health center, or how do you, I guess, find the patients you're going to help in that program?
So yes, to all those potential areas that we can receive referrals from. Right now, we already have a couple of individuals that are on the list to be like our pilot individuals for the program. And we received all of those referrals through our CCRT program. So other programs that individuals may be needing more than what that service can provide to them, can refer to ACT. Also, we are going out to Carl and some of the other areas to let them know of this program, because I can see us receiving referrals from them. And then our leader goes and interviews them and makes sure they meet the criteria for the ACT program.
And then how do you make sure that, I mean, obviously these people are not, always, wanting the, services. So if they decide to decline further engagement, do you still try to follow up with them, or how does that work possibly?
Yes, I mean, our follow-up will be still intensive, more intensive, to make sure that these individuals can remain engaged as long as possible within the program. That is definitely a skill that that team is going to bring to the table, is that engagement component.
Thank you.
There was a question in the chat. I think Lynn could have put in something there.
I think my question doesn't, my answer doesn't really apply to the long-term sustainability. Lisa Benson is posing a question about what will happen to sustain these services over the long term. I think that's a great question, but it looks like at the moment, the federal government is taking this pretty seriously. So.
And part of the sustainability too is coming from the state as well. The state is adjusting some of what it will and won't pay for. Currently, as we speak, they're reviewing some of these things to try to align more with where the federal system is going as well. So it's a great question, as always with different programs and the ever-changing face of funding. We're definitely looking at all of those pieces, and sustainability is definitely one of the issues.
As a psychosocial rehabilitation program, like a day program for individuals, something that's being considered or part of any of these programs, or is that not considered part of the case management at all?
I was going to say, while it's not like your traditional PSR that I think many of us miss, the living room, I think, can serve as somewhat of a replacement. There are, sometimes peer-run groups that go on within that, and individual, case management abilities. But yeah, I think they got rid of that term.
Okay, sorry, old school here.
No, I missed that too.
Yeah, and it was a really great program a lot of times. So especially for those that are really isolated, to have, because then they kind of are not just a drop in, but more of a regular, so to speak. So that was a good situation. Thank you.
Yeah, Dr. Maurer, I don't know. I don't know if I ever ran into you, but I used to work at Lifelinks, and that PSR program was great. And that was a wonderful model that I wish was still around.
Me too.
Any other questions or comments? Okay, that's presenting that. Thank you very much, those grads.
You ready for the next presentation?
I think so.
That was really great. Thank you all.
Thank you.
I'm not going to do the next presentation. Mr. Leon Bryson Jr. is going to do it, but I will show the presentation on the screen and just tell you that this is a student project with, I'll tell you the ending now, which is that these young women got the very highest possible scores for their work with us. This was an amazing experience for us. They also, I tried to come up with comments that were like, that actually expressed how important it was to me, but it probably sounded stupid. I meant it though. But anyway, this was a collaboration between myself and Mr. Bryson and Kim Bowdry. And we started with 3 social work students and ended with 2. Really important topics. So I'm going to share the screen, and then Leon, let me know when I should advance each slide.
Gotcha.
Okay.
All righty. So thank you, Lynn, for that introduction. And yes, it was a pleasure to work with them, hardworking individuals. We spent approximately 3 months working with them on this project, and they did an outstanding job. And so as I go through this presentation, I want you to think about some of the issues that are being faced in the IDD area, the intellectual and developmental disability realm. I want you to think about that on the MH side. So here we go. So hold on. So next slide, please. So these ladies spent time doing literature reviews. They conducted interviews, created and conducted interviews and surveys. And so here's just a list, a small list of the literature reviews that they researched. So they looked at Kansas, they looked at Iowa, and I believe also Ohio. Next slide, please.
Oh, sorry, I went backwards. Okay.
No, you're fine.
Okay.
All right, so here we go. So some of the concerns that they were able to discover in working and learning about the DSPs on the IDD side was low wages and lack of benefits. They also had major concerns with the lack of support from supervisors, the nature of the work, the increase in need, and the lack of adequate training and promotion opportunities, which were limited to them. Next slide. So here is a slide that talks about the approximate DSP salaries. And so from left to right, you have Illinois, Champaign County, and the nation. So Illinois DSP worker makes average around $17,641. Here in Champaign County, it's approximately $20,000, almost $21,000. Nationwide, we're looking at $22,000. So 22,149. Per hour in Illinois, it's only $8.48 an hour. And so we know that Illinois ranks 49 out of 50 states nationwide for DSP salaries, which is very sad. Next slide, please. So what did the DSPs had to say about their pay? Well, as you can imagine, the top one, it wasn't great. Pay is not great. It is tempting to pick up extra hours, extra days and hours due to the low pay. The field needs more pay as it constantly compete with hospitals and nursing homes for employees. DSPs constantly work nights and weekends, so they would rather work at a hospital where this is not the case and the pay is better. This is especially true if they have higher education. Low pay gives DSPs no incentives to stay. Next slide, please. So interviews with DSPs, virtual interviews conducted with DSPs and their experiences. So first point, often work long, hard, inconvenient hours, which is a violation of their rights. A lack of work-life balance. Salary was not livable. Communication issues amongst employees at all levels. Did not receive adequate training. Very minimal interaction with or support from supervisors, which is very key. Racial inequities and inequalities were prevalent. Lack of diversity among staff and lack of cultural competency. Staff to patient ratio was not ideal. At times it was 1:8. So think about that as, you know, you're trying to work with people and you can't get to them because you have your own issues. You have things in front of you, and I'll go to it. It says little to no time to work on rights, happiness, and or enrichment of the individuals with IDD. Their work, they work with instead focus was on meds, meals, and mobility. Meds, meals, and mobility. That's heavy. So you can't even get to the client because you're dealing with other things in front of it. Next slide, please.
Oh, sorry, I'm having a hard time getting to it.
Oh, no problem.
Here it is. There.
Okay.
Okay.
So what can be done? Increase pay, number one. Approximately $9 an hour in Champaign County. Livable wage in Champaign County is $14.98. Poverty wage in Champaign County is $6.13. We want to increase awareness of job description and pros and cons with it, such as the stigma that's attached to it, experiences with individuals with an IDD to gain interest in the DSP field. More opportunities for promotion. Serve broader spectrum of people. Higher priority, better funding allocations for Illinois for services, and more supportive supervision. Next slide, please, Lynn. Here's a novel idea. Give them credit. Give them credit. Communicate. Creative workspace which welcomes self-advocacy and improvement. Also, know their strengths. Reward and acknowledge positive work efforts and attitudes. And ultimately, it's the community. Create a community within the workplace which cultivates a deeper friendship. And so if you look below, I'll see if I can read that.
I'll try to blow it up. I kind of messed up this morning, but maybe getting better with experience.
Oh, we're getting there. I'm just aging, Lynn.
I can't. Okay.
Besides increasing your pay or benefits, what is the most important thing your employer could do to make sure you stay with them for the next 5 years? And so as you look on the scale here, we have provide new career opportunities, provide new leadership opportunities, provide more professional development opportunities. Give me a better supervisor, show more appreciation for my work, and show more respect for my experience. And so if you look at the bottom, we have DSPs who have been in the workforce for 6 to 9 years. 6 to 9 years experiencing a lot of the hardships that they're going through. Then we have some who have been in the system, who have been in the workplace, force for 11 to 19 years. And then there are those who are, diehards. They're here to help, serve their communities 20 plus years. Next slide, please.
Oh, see, this is where it got weird
I
before.
know.
Okay, I'm sorry.
No, you're fine.
Okay.
All righty. So
There it is.
want to promote racial equality. Make sure that everyone is treated equally. The DSP mentioned that they had been asked to sit in during meetings for an increased racial diversity and was told several times by their supervisor to fit in, to fit in. How can we address this? Require all employees to have cultural and racial diversity trainings yearly or as needed. Encourage friendly relationships. Acknowledge the problem, provide support, discuss more acceptable behaviors. Next slide, please. Promote a better work-life balance for everyone. So there's a few steps that they highlighted. Step 1, decrease the amount of hours DSPs work while increasing their pay. This will allow time for self-care, which will likely decrease the turnover rate. Sounds basic, but it makes total sense. Step 2, increasing the amount of DSPs per person served. This would create less stress and the nature of the job would be more manageable. And then the third step, develop and improve working environment. This can be done by providing supervisors with necessary training to be effective and supportive mentors. The crisis also represents an opportunity. Future of the DSP workforce. So Sedgwick County, they have a recognition program, multimedia community, recruitment campaign. In Polk County, they're professionalizing DSP's workforce. DSP workforce credentialing, multimedia community, frontline supervisor and curriculum monetary incentives. In Ohio, they're doing community connections, career partnership, 2-year programs which exposes high schoolers to the field through classwork and internship program. 32% graduates are employed in the field. So in summary, DSPs are essential workers who are being overworked, underappreciated, and paid well below the national livable wage. The DSP workforce shortage needs to be resolved to decrease employee burnout, turnover, and to increase the amount of individuals with intellectual or developmental disabilities who are able to receive services. This can be done by increasing pay, requiring supervisors to complete yearly trainings regarding race and ethnicity and competency, and being an effective mentor, allowing more areas for promotion, showing DSPs they are appreciated and supported, and being sure they receive adequate training. So how did the students contribute to this? Well, they increased the awareness about the DSP workforce shortage. They conducted research and conducted literature review on the topic at hand. They provided a fresh viewpoint to the topic to Lynn and myself and Ms. Kim Baldry. They conducted interviews and created a survey for data collection. So they were very instrumental in this in this project. And so that concludes it. Something to think about, certainly, not just on the DD side, but also on the mental health side as well. And ultimately, it's about caring for others. And so we all have an obligation to take action.
There's in the board packet, there's also the survey that they developed, which, we haven't implemented this. In some ways, I think some of the solutions that they explored are probably not really getting to the point. Like if we think that people should be paid more than, for the job they're already doing, then paying them to do educational opportunities on top of it sort of maybe undermines, like that message. And similarly with a questionnaire, I think continuing to ask DSPs what's hard about their job when we've got lots of national survey instruments now, and Illinois has looked into this, and it's not about the money, it's about the money. So I think this is a really great survey instrument, and we would like to talk to y'all maybe in the spring about ways we could use this to learn more or to even create like a set of opportunities for additional payment for DSPs, but it is very hard to solve this problem. This is the real solution really probably is a top-down one, because DSPs in the DD field are funded through the Medicaid waivers, which are the state and federal partnership. Our agencies are prohibited from taking additional payment for those services. So your funds can't be added to help increase the salaries because that constitutes Medicaid supplementation. This is a problem across the entire country. Before the pandemic, the prediction was that we would need to create something like over 500,000 new DSPs every year to meet the needs of people with developmental disabilities. Since the pandemic, that workforce has been, I think turnover has gone up something crazier than any other field, and the shortage now is like 75%. So this is a real crisis in care, and I think it's really going to be worth our time in the spring to explore some solutions, but our local solutions will only go so far. That's important. But we really enjoyed working with these students, and I think they gave us a great foundation for further discussions when it's time.
Any comments or questions?
Just a quick one. Is this it for these students, or are they doing any further research for us?
Well, they have internships now. One of them talked to Mr. Bryson about there's an internship over the summer that the School of Social Work pays students to do, which, she could work with us on a survey instrument for mental health needs. So, it'd be a shift, but she's a social worker, so she's got some really great context for mental health services too. So, I think there's more to it. Like, we might have to apply for that, and we haven't looked into it yet, but no, they're done with us, but they were really great to work with. I think we got really lucky this year.
I do have a question. I was wondering, we've discussed this, several times already, and it seems like you said, it has to be a top-down approach where we actually just increase their pay, because otherwise, they might as well just go work at Target or Costco and make $15 an hour. There's no point, and unless they're doing it out of the goodness of their heart, but at a certain point, you burn out. Is there any thought, or do you guys talk with our local state representatives about legislation to improve this?
I think our state representatives are on board for improving the DD workforce. And there is some, the biggest appropriation ever happened this year for to start solving the problem, but it didn't even get close to what the recommendation was from experts on what we really need to do to fortify the workforce. So I'm starting to advocate at the national level for the first step is to identify a unique occupational classification for these workers, because they don't, with the Bureau of Labor Statistics, and that they don't have their own unique classification. And that's where, if they did, you could build the case for what the work really is. It professionalizes a nice word, but there are lots and lots of people who understand what this work is and what makes it what makes a good DSP. So having that unique classification gives an opportunity to fill in with what, good descriptions about what the work is and why it's important, and then advocate for adequate pay. So that's a step that a lot of advocacy groups have been talking about for a long time. We're really pushing for some legislation for next year to make that happen. So. But it's just a start. And meanwhile, communities have to deal with this. So hopefully we can find some way for the local funds to maybe mitigate the crisis.
Well, and I have mentioned before that, I've worked in this field, and, and we were talking a little bit about the money aspect of it. Yeah, I mean, we all want to make $15 an hour, but I kind of compare this field as, those who teach. teachers don't teach to make a lot of money. They teach it because of the students changing lives, things like that. And so, not all, but, when I was in this role, someone being able to write their name or something was such a joy to them. And so I might have been getting paid less, but I had other joys in my job. But that only goes so far when you are sitting in poverty, when you leave that group home or whatever. Another thing that struck me was they're talking about picking up more hours and things like that. The type of person who works in these, occupations usually are so kind-hearted. They know if they're short-staffed, they're like, yeah, I can stay late. Yeah, I can pick up another shift. So unfortunately, the wonderful folks who take these jobs are kind of falling right into the pit. And we can't bring a surplus of money because, like I said, I keep aging myself. Now we're almost at 25 years ago I did this, the money wasn't there. It's not, then it's probably not going to be now, but there was a phrase in here about, cultural awareness and things like that. That is something as our board that we can help with. We can say, hey, we want the, the DS or not the DSPs, but the QMRPs or whatever they call themselves now, we want you to come to this free session. We're going to talk about kind of how to treat your people, because I think our whole nation needs a lesson on how to treat your neighbor. And so maybe that's something we can offer as a service of, telling these managers, we know you're just as burned out as your staff, but sometimes saying, hey, I saw how you helped Jason, tie his shoes today, means something that you commented, you saw your employee doing something. So, okay, I'll get off my soapbox now.
Great perspective. Thank you, Jane. I mean, that we did turn that up I think that was covered with what the students found. Like, part of this is about not getting in the way of why people love their job. Like, they love their job. They wouldn't, they wouldn't do it if they didn't. So how can we help not get in the way of that?
Thank you.
But you didn't ask that question, did you? What do you love about it? That wasn't part of it, right?
No, they
Well,
did.
that would have been interesting because you could support those things,
There you go.
Lynn, if we are going to talk about it in the spring, this is why I was asking about if they were going to continue. It would be nice to have some follow, like, for example, the fact that Illinois is 49th. Some of the background and market forces about why that is would be kind of helpful, because if it is, like you were mentioning, Medicaid and stuff, but that's going to be nationwide. So why is Illinois even below that?
I think Kim Bowdry and I can provide all that context.
Yeah, so that would be helpful for that conversation.
Definitely, we can do that.
Mississippi is doing better than us. It's not good. Okay, any other questions, comments?
Well, now you're ready for the action section of the board meeting. There's kind of a lot of action. I hope that you have spent enough time with these documents to be comfortable with the drafts that we've achieved at this point. And also to know that we'll be working on these soon. Again, the year goes fast. We'll be working on new versions of them before you know it. So if there are things that you think of after, that you'd like to see for next year, we're already talking about it. Okay, so here's the first one, is the 3-year plan.
So for the 3-year plan on page 52, it says increase influence on policy at local, state, and federal level. I was wondering, do we want to assign someone to contact local or state representatives to talk about issues to pass like to promote or advocate for legislation?
Well, so the 3-year plan is essentially it's the mental health board staff agreement to what we'll do for you. Some of it is done through the allocation where we're contracting out with agencies to support the priorities, but that kind of advocacy that's stuff that we can do. And we can involve board members in it too. There are times of the year when it's really helpful to write a bunch of witness slips to communicate all as a group with our legislators. Does that help?
Yeah, it does. I know like the American Academy of Pediatrics has like a lobbying day where we go to Springfield and talk to legislators about issues that are important to families and children, or at least contact them. So I thought, like you said, having like either board members either write witness slips or contact their local representative can be helpful in just promoting and advocating for certain policies that are relevant to the mental health board.
There's both of our state association and the national associations have legislative focus too. So they'll send information sometimes about things we could consider advocating for. So I can share that information out when it comes.
Discussion. No further discussion. Motion to approve.
I'll move to approve the proposed 3-year plan for fiscal years 2022 to 2024 with fiscal year 2022 objectives.
I will second that motion.
Is there any more discussion? Okay, I'll stop sharing so that you can do roll call.
Matt Hausman,
Yes.
Daphne Maurer,
Yes.
Elaine Palencia,
Yes.
Kyle Patterson,
Yes.
Julian Rappaport,
Yes.
Liz Randall,
Yes.
John Paul Joachim,
Yes.
Joe Omosage.
Yes.
Ready for the next one?
Yes, please.
Okay, this is the allocation priorities and selection criteria for the next round. So applications can be submitted between January 3 and February 11, and then we'll spend a bunch of time in the spring looking at applications, and this is the guiding document for that.
Any questions? And I know Daphne and Matt, this would be your first round through this year. Any questions about how you go about it? Or comments?
I just have a linguistic question.
Oh, boy.
Uh-oh.
No, just a word usage. In the thing we just voted on, you had replaced underserved and underrepresented with underinvested a lot. And on page 71 of this one, you still have the old designation, if that makes a difference.
Well, I think
Just say,
the meaning is roughly the same, but I should have updated that. I apologize.
well, I wasn't sure why the substitution. Underinvested, who's underinvesting? We or the people who are being served are not investing in their own selves?
Well, probably all. I think it's
Okay.
to sort of focus on over the last few decades, the federal investment in
Uh-huh.
communities and in the safety net system has declined, and they sort of kicked it to the states who also then kicked it to local communities. So I would say there are large groups of people that we've all failed, you know, and this would include the populations of interest, people with severe mental illness and developmental disabilities and substance use disorders, and also communities of color, people who live in the rural areas where there are no more service providers, and it's becoming, you know, questionable of whether service providers will ever return. So, you know, the focus, I mean, we have, Champaign County seems so little, but we do have some deeply underserved rural communities. And so the idea is to start calling this an underinvestment rather than, you know, to sort of move the responsibility.
Okay,
Yeah.
that's what I thought you were doing, but I wasn't sure how important it was to the documents themselves. So I'm just saying on page 71, we could, at the top of page 71, put underinvested to replace underserved and underrepresented, if it matters. That's what I wanted to know. How much does it matter, the language?
It's not hard to make an additional change.
Okay.
So if you all like that and you make if someone makes a motion with that revision, I can do that. It's at the top of page
71.
So I see historically underinvested in one spot.
Well, no, right at the top of 71, it's
Oh,
underlined.
it's the title. Yes.
Yes.
Okay. Well, yeah, actually I would probably leave it because that's sort of I mean, we could, it's up to you all. I can do it. I'll change it.
How important it was to our mission, let's say, if something else had been, you know, pulled into that and I didn't. So.
Well, if it's okay with y'all, it's a shift in focus. And I think that's why we love wordsmithing.
It is,
Yeah.
it is also, Lynn, just because when I was looking for it after Elaine pointed out, it is also under the inclusion and anti-stigma section. You use the underserved and or underrepresented again. So I don't know if that's one you want to
Okay,
change as well.
thank you. I will.
Okay.
Any other
Found it.
questions and comments here before we move to the motion?
And I didn't say it, but I think I should also add, you know, this is also a really complex community, and there are users of other languages that we now need to really make some extra effort to reach. So I think that's also under that same category. Anyway, sorry.
Oh.
Did you all make a motion? I need to
No,
stop
motion
talking.
never made yet.
Okay.
So we make a motion to this section.
I'll go ahead. I move to approve the CCMHB program year 2023 allocation priorities and decision support criteria as described in this memorandum with the suggested edits.
Okay. I can second that.
Second.
Are we ready?
Yes.
John Paul Joachim,
Yes.
Matt Hausman,
Yes.
Daphne Maurer,
Yes.
Elaine Palencia,
Froze.
You didn't hear me again? Yes.
Kyle Patterson,
Yes.
Julian Rappaport,
Yes.
Jean Sprandel,
Yes.
John Paul Yuki, or I'm sorry, Joe Omosagi.
Yes.
Ready for the next one?
Yeah.
We're getting there.
Yes, we are.
So in this one, this has really been a labor of love. Y'all have given me some really great suggestions, and we've incorporated everything. I think there are even 2 different colors of highlight now. So, and also remember, it is okay for us to revisit these documents because time passes fast and the world we're living in changes too. So if you see things later that we need to revise for the future, please let me know.
Two questions.
I had page 89 or page 13 of the actual memo. It says in part E, termination of funds. The mental health board requirements within 90 days of notification of suspension of funding or repeatedly fails to comply with the requirements of the mental health board. So how many times is repeatedly? Like, will they be like, is that just up to our discretion, or it was a little vague in the language? So I was just wondering.
I think it has been so far up to discretion because this, we don't bang into these problems very often, and we learn a lot when we finally do. So this has been, so far I've relied a lot on the officers to tell me like, no, we need to take this to the full board, or you can try to solve this. So repeatedly, I think implies more than once. I mean,
I think it is good that it is very giving us more, like judgment to make these determinations, but just want everyone else to kind of realize that it is vague and that they're okay with that.
Did I land on the right page?
That's the correct page. It's part E.
Oh, okay. I see it.
Any other observations or comments?
Go back to the motion, sorry.
Yeah.
I hope that's not making you dizzy. It's kind of making me dizzy.
Any other questions or comments or observations? If not, go ahead and move the motion.
I'll motion to approve the proposed Champaign County Mental Health Board requirements and guidelines for allocation of funds.
Second.
Any other questions or comments? Roll call, Stephanie.
Matt Hausman,
Yes.
Daphne Maurer,
Yes.
Elaine Palencia,
Yes.
Kyle Patterson,
Yes.
Julian Rappaport,
Yes.
Jane Sprandel,
Yes.
John Paul Yuki,
Yes.
Joe Omosagi.
Yes. So updates.
So there's not a lot of news. I updated it with a little bit of additional price information. We're kind of stuck because at this time of year, it's difficult to get bids on the kind of work that really needs to be done before the house is relisted, so that the main focus is right here in the last paragraph. We've got to fix that subfloor and what happened in the bathroom, the broken shower pan. So December 20th is Monday. That's when we get a second bid. And at that point, we can choose of the two bids and engage in the work. And once the work is done, hopefully we'll relist the house. The real estate agent offered us a new market analysis. Things have not gotten worse with the market since the house was originally listed, but who knows what's going to happen? Unprecedented times. So we're just not to the point where we can relist it. So I like this. I like that he gave us the market analysis, but there's really nothing much for you to do with it right now. Please keep in touch with me about any concerns. So that's all for that. And then here's the fun stuff. Schedules. Happy New Year. I also want to just let, if there are still people from agencies here, let you all know that the deadlines for all of our reports are in every board packet. They're in italics in these in this important dates document. And this is also posted on our website. And it's also, those dates are also included in contracts. We just get a lot of questions about deadlines. And so we're trying to make sure that information is always available. So
several different platforms.
yeah.
I feel you, Lynn. I know that.
I mean, it is hard to keep track. So we're just going to put it in there every time. So.
But just repeating yourself, I feel
Okay.
that.
That too.
Yeah. So I guess it's agency input time, Joe. There's no more action. It's all like information and discussion from here on out. So yay, you did it.
Everybody left. So something.
It looks like no agency input and no one is here either.
Yes.
You want PCDDB input?
Oh yeah, sure. Good.
They did the same stuff this morning.
So we're on the same page.
The end.
Yeah. Staff reports. So if you have any questions about staff reports?
I was just wondering, it seemed like, there was a lot of agencies that hadn't returned their audits yet, only 5 turned in so far under Stephanie's report. I was wondering, is this typical or have more come in?
They're not due yet.
But they're due in like 2 weeks.
Right. We did get another,
Come on, man.
we got a
No,
big one
no, no.
today. So we've got 6 now, maybe 7. Stephanie could update, but the one we got today was a big one. So yeah, we're going through those as we receive them. Not looking forward to getting them all at once. There are a couple of agencies which use a different fiscal year. So those were due in June. And then they'll be due again in June. So yeah, so I guess, I wasn't really worried about it, but I am thinking about like, oh no, in January, we got to read all those.
Mhm.
Thoughts and prayers.
Yeah.
Got to be hard to do holiday shopping and do these all at the last minute.
Yes. It's just such a different language. I kind of get the hang of it, but I like in our staff reports, we're all talking about each other. I kind of like that. I especially talk about everybody else.
One thing I was wondering about on page 117, it says, that the documents are accessible for technical assistance with the registration application. They can contact Stephanie. Is the application available before January 3rd? So they can't look at it until January 3rd, the agencies
Right.
to fill out the application. So they have basically like a month and a week to fill it out.
They can look at the application instructions, which are already posted. And now that the priorities documents are completed, they'll be able to look at those as well.
So they'll know what kind of information they need to gather before the application comes out to fill
Yeah.
out.
And they'll know how to fill out the application. Those application instructions are really boring, but we're going to make them, we've really tried to make them better this year. We're going to try to make them even better next year.
Oh, and I had just one other thought, Lynn. I didn't know if this is possible, just as like a thought to throw out there. You know, instead of funding, I mean, obviously, like we've gone through all the ways to fund SILAs and pay, you know, DSP workers more. Is there a way to maybe have like, would it be possible for us to have like a grant or like a fund for families with people with mental health or that would qualify for their family member being in a SILA, to give them money to hire someone for home to provide care for respite services, like for short term when they need a break? That's just a thought.
Well, SILA is problematic because it's 24 hours a day, 7 days a week. So the promise that the state makes is that this is all the care you need.
Yeah, but if these people would qualify for SILAs, but there's none available for them to put their family member in, they're obviously taking care of them at home.
Right. No,
Right
the
up.
TD board funds a lot of programs for folks in that situation. And the mental health board has done so in the past, but this last few years, the focus has been on very young children, but that's absolutely a possibility. Yes. And oh,
Okay.
I thought there was another question. I'm sorry.
Okay. Thank you. So, any other questions about staff reports? Board to board.
This Daphne, I attended the Rosecrans board meeting, and it's fairly exciting with everything going on, of course, as the presentation represented, but also their big exciting kind of decision was that they are going to invest in their workers and increase pay. Even though it's going to put them at a deficit, they're going to make the investment in the workers, and they're confident that this will lead to positive changes for their agency. Also, they are really, really wanting to become very strong in Champaign County with respect to the child and adolescent sections of our populations we treat.
Reports. Julie wasn't here when we started the meeting, so Julie, do you have anything you would like to say? Please, this is your official last meeting with us.
I don't think I understood what you said, Joe.
Okay, I was just saying, is there anything you would like to say since this is officially your last meeting? That's right. Oh, come on, Julia. I know you have a little bit more than that.
Well, this is my last meeting, so I've been doing this for 2 full terms plus another year. It's plenty of time for me to decide that I am sure it is now in great hands. And actually, I mostly have a feeling that the staff of the mental health board need to be praised. That's my most clear feeling about those 9 years, was over 2 different administrations. Peter Tracy, who preceded Lynn, and then Lynn ably taking it in a whole different style, and yet also doing great things. And not just Peter and Lynn, but Mark and Stephanie and Chandra, and I'll forget everybody's name in a minute, but I think that this board can rely on this great staff. And what I don't know is that the county has even the vaguest understanding of how much work this staff does to benefit the people of this community. And so I guess my parting thought to continuing board members would be anything you can do to make this known to your county board representatives or your local people in your neighborhood. Talk about this. These folks really work hard, and those of us who serve on the board as citizens have a different role, but they do all the really heavy lifting. And so I'm grateful for them. I've learned a lot from them, and I have every confidence that you'll carry on. So thanks for letting me be a part of it.
Thanks, Willie. So Julie, you want to move to adjourn us today? Any other questions before Julie adjourns us here?
Well, I move to adjourn and look forward to having dinner every Wednesday of the month in my future years.
Thank you, Julie. Need a second with that. Who's seconding? Okay. Have a great break, and we'll see you all next year.
Okay.
Okay. Bye. Bye, Julie.